Hi, I'm Bill Kristol. Welcome to Conversations. I'm pleased to be joined today by Jim Capretta, a resident fellow at the American Enterprise Institute, served at senior levels of the Office of Management and Budget of the Bush administration, before that on the Hill, before that as a career civil servant, I think, at OMB, which is the best part of the U.S. government. I'll say that on my own ticket. I hope that's still true. It was true when I was in government.
Yeah, I tend to agree.
People who know a lot, who care a lot about having programs that work as opposed to having kind of an investment the way people in the agencies have on it. So, but you supervised the health programs in the Bush administration, so you had a kind of comprehensive view of the U.S. government's efforts in healthcare, and you've written a ton on healthcare since. So, let's talk about healthcare.
Absolutely.
Kind of a big topic, right?
Yeah, very big.
So what about healthcare in the U.S.? It's good, it's terrible, it costs too much, it's destroying, it's going to bankrupt us? What's at a 30,000-foot level, what's the basic, where do we begin? What's the truth?
Yeah. Well, the U.S. has a mixed public-private system, so it's a complicated system. But I would say that at the very highest level, we should be grateful that it is an open, adaptive system. That is, it allows for change and introduction of new therapies, new ways of taking care of patients, new medical technology, in a way that is resisted a little bit more around the world, especially in other high-income countries. So the U.S., really, if you're someone who is in need of significant medical attention, there's no better place in the world to get health care than the United States. Moreover, through a lot of change and adaptation, most Americans have pretty ready access to that amazing system through their employer-based health insurance, where the vast majority of working-age people get their coverage, through Medicare, if they're 65 and older or disabled, and even through Medicaid, which is a program focused on lower-income Americans, but also allows for pretty ready access to this vast network of hospitals, physician groups, clinics, labs, all the rest of it that comprises America's delivery system for care, which really is excellent in most cases.
I mean, I'm surprised you say, I think, on the surface, one could be surprised that you say open and adaptive, because an awful lot of people's interaction with the healthcare system seems awfully bureaucratic and, I don't know, backward-looking almost, or not, takes forever to get stuff adjudicated, or they have 3-year-old standards for what should be done, or the insurance companies and so forth. So explain a little bit more about
mainly on the clinical side of the house, right? It's quite true that America has a bureaucratized system of insurance that is cumbersome and a lot of people are frustrated with, including myself, and we talk more about that as we go. But on the clinical side, that is, what the physicians are doing to patients as they're coming in. Think of cancer, think of heart disease, think of things that a lot of Americans are afflicted with, diabetes care and so on. And it's really advanced. It gets better all the time. And that's because there's a lot of people trying to make it better through research and other efforts. And once something is found to be working better than previous standards of care, it gets introduced fairly readily in the United States. So once it's proven scientifically in the journals that cover the specialties and so on that a new way of doing something is going to be better than an old way of doing something, we move pretty quickly in the United States to doing it the new way. And the physician community is fairly well plugged into a pretty vast network of information about how to figure out what's going well and what's not going well. And so, it's far from perfect. I'm not trying to be Pollyannish about it, but relative to what it could be, that is, if the government really, tried to be more rigid about cost controls and controlling when things were introduced and so on, it's fairly open and adaptive that I think really accrues to the patient's benefit.
And I suppose drug companies being able to make a lot of money off drugs helps?
Well, I mean, that's a big issue and a big question. I think on drugs, what we should think is that you want an incentive for these researchers to come up with the next big, great thing, right? And what's the best way to incent that to happen? Is through money. Yeah. I mean, and so we have a pretty...
Plus it costs a ton of money to...
It costs a ton of money to do it, and that's mainly, especially for products that would have widespread application, you have to do very large clinical trials, which are really, really expensive. And so to get through that hurdle, you need a lot of investment capital. And the only way, where does that come from? It's going to come from investors. And of course, investors invest in such a thing if they get a good return. And so in the United States, we have a pretty open and good system of investment money essentially fueling research on the next big, great thing. And, to my mind, that's a good thing. That's not a bad thing. I mean, that's the way the United States ends up dominating the development of new product developments that
does
occur.
it? Because, one could imagine in some theoretical way that you could have a very strong, NIH sort of times 20 or 200 and government funding a huge amount of stuff, but get rid of that profit, excess profits, and get rid of the bureaucracy of all these drug companies or whatever, and, certain kinds of competition which maybe aren't optimal because, whatever. And I don't know, but I guess we would know. I mean, do we have a sense of how much of the actual medical advances, leave aside in a way the bureaucracy side of it, but the actual, as you say, clinical treatment of people? I mean, would we, I guess we can't know for sure, but would we be getting more of it or less of it if we had a radically different system? Are there other countries that are as developed as we are that, I guess there are, that have different systems?
Certainly there's a lot of research and effort to go into, countries like Japan and Germany and the UK and elsewhere, France, elsewhere. There are lots of researchers, very good researchers globally in high-income countries that are working on all the same kind of questions as the U.S. And they do, I'm not saying that the U.S. is exclusively the source of everything here, but I would say, lots of studies have looked at this, and roughly about 2/3 of the product developments that really end up disseminating globally, originate really in the United States. That's both on the device.
Way beyond the pure, what you'd expect from just GDP.
Just the numbers of the
Germany
the
and
population.
Japan have huge economies and smart scientists.
So we tend to dominate the biopharma space and medical device space to the same degree. And I think it's really relative to the adaptability and openness of our system to essentially paying for it if these things do come online and when they are successful. Now, with respect to the question of let's say we got rid of this whole industry and just said, let's have the government do the research and also then try to translate the research into product development, which is really the key. And I think it's that second step where a commercial sector just is far, far superior to a governmental sector. How to take what's being learned about some basic scientific understanding of how the body works and then translating it into a pill or something that you can administer to a patient, that's no small thing. It takes a lot of work to get from one to the other. And that's where our commercial base can, really excels, and where sort of a strictly governmental approach, I think, would fall short. I think you could ask the people that work in NIH, and you might get some people saying, yeah, we could do it. But I think a lot of them would say, no, thank you. That's not our skill set. We get it so far, and then we need a commercial sector to take it, the last mile, really, to a product that can actually be administered to a patient.
And to have failures, too, I suppose, which
they fail
the
all the
private
time.
sector is good at kind of internalizing and expecting, and, the stock price goes down or whatever, or up, but as opposed to government, where if you have huge investment and then it doesn't work out, people have to be fired, or there's congressional hearing. You know what I mean? There's a way in which the private sector makes it easy. And if the field, as I kind of think it is from my limited knowledge, is one where there's a lot of experimentation and a lot of things don't turn out the way you expect. Drugs work for disease A, not for disease C, even though they were primarily originally developed for disease C, or maybe disease C plus. I mean, you do want a system that's more experimental and shielded a little bit, I suppose, from politics, right? I mean,
absolutely, you want to shield it from politics because, imagine if NIH was totally responsible for trying to, take the next step on all of these things. I think the level, like you had indicated, the accountability ends up with funding cutoff, right? And in the private sector, people lose money, but that doesn't mean that the enterprise completely comes to a halt. They have 10 projects going on, 8 of them fail, but as long as 2 hit, then the company survives and carries on. So I do think the commercial model in this particular respect is superior.
Yeah, no, I'm glad you're sort of making this point just about the actual quality of care. So much of the discussion is about the cost, and it's legitimate, and who pays for what, and access to it, and universal coverage and so forth. But it is important to step back and realize that I always think of it this way because I first came to Washington to work in the education department. And education spending has gone up a lot over the last 30, 40 years, probably not quite as much as healthcare spending, either in terms of GDP or government share, but a lot. There's not much evidence that education results are any better. Now, maybe that's the nature of the enterprise. You're teaching this in the next wave of 6-year-olds reading. It doesn't, we don't get more efficient at it. But whatever you think about healthcare, we spend a lot of money on it. There's no question that healthcare is better than it was. An awful lot of people we know are living good lives and high-quality lives who wouldn't have been able to do that 20, 40, 60 years ago. So in that respect, I think that some of the anger at healthcare or the impatience about healthcare is a little, I don't know, not overdone, but it's not a failing part of the U.S. economy or society. It doesn't seem to be.
No, I think the actual, people expect a lot of the healthcare system, some of which is unrealistic. But in terms of the basics, where elderly people getting, artificial joints, the knees and hips and other joints now as well, that's a big deal. I mean, because there's so many more people as they go into their older years now who are mobile in a way they were not 30 and 40 and 50 years ago. And that mobility allows them for the rest of their body to function better over time. They don't fall into a pattern where they decay over time. And so the ability to allow people to stay functional and up and about and doing things and active is a huge benefit. That was developed over the last, few decades.
Right.
And it's now very widespread and common. Also, heart disease was a huge problem. And now many people with early stage heart disease are treated successfully and live long lives without any incident. And that's all because of better therapy and attention to what needs to be done to make sure that person can continue to function. So those things are real big success. And of course, cancer. I mean, all the advances on the cancer side. And there's the oncology treatment system is far superior to what it was 3 and 4 decades ago for most cancers, not all, and the survival rates are just way, way up. And that's all due to essentially a lot of scientific effort and research into how do we do this, and then dissemination of that those protocols through our system in a way that most people, I'm not saying it's guaranteed, but most people have pretty ready access to that system of care when they really need it.
And sticking on the quality side just for one more minute, and then we'll talk, of course, about how to pay for it and who provides the insurance system and so forth. I mean, are there any obvious, reforms there that would sort of be helpful? I mean, are we putting obstacles in the way to medical progress that you see, or is that side of the equation reasonably well set up in the U.S.?
I think it's reasonably well set up. I think most of the danger is public policy kind of worrying about the expense of it and intervening in ways that could impede real progress. So our knowledge base, and of course just the introduction now of possibility, big data and artificial intelligence intersecting with the scientific enterprise in a way that could improve human health. People are working on this, feverishly, and the promise of that is pretty stunning if it pans out over the next 20 and 30 years, right? And in a way that could be very beneficial. And so the danger really is the government trying to get involved in that in a way that might impede real progress by trying to limit the expense or cut off the ability to make returns on it and so on. But as long as it's an open system that allows for investment money to sort of chase how to disseminate new therapies and new ways of taking care of patients, I think that side of the house is pretty good. Now, that doesn't mean American healthcare is high quality in all instances. It's a fragmented, somewhat chaotic and disorganized system for a lot of reasons. And so people fall through the cracks. And there's an awful lot of burden, unfortunately, on the patient to navigate a complex care system, to know when they have to go here or there, connect this to that. And so I would say...
And not all patients are in great shape to do that because they're elderly or they have other problems.
So things get misdiagnosed because of poor information flows, lack of communication, poor understanding. It's a fragmented, little bit chaotic system. And that means that some people, unfortunately, do fall through the cracks on the quality side. They're just not getting a the right kind of care they should have gotten if people really had properly understood what their problem was. And that happens, all too often. And also, honestly, there are just lapses on following good protocols in the care delivery system. There's a major report 20 years ago that documented that, one of the most dangerous places to be if you're a patient is in a hospital, basically, right? Lots of things unrelated to your problem can occur in a hospital, infections and other mishaps, quality problems. And so there's been more attention to that over the last 2 decades because of that major report, and some improvements have been made, but it's still lacking in terms of where it should be.
So on the payments on the provider side, so most Americans, working Americans, mostly get their health insurance through their employer, which is sort of a historical accident, right?
Yes.
Somewhat unusual, I guess, in the developed world. I mean,
yeah, except for Germany, which pretty much built its system on a similar kind of anomaly that occurred there. They have basically an employer-based kind of approach to working age insurance. The United States does stand out. Germany has evolved into a much more regulated government organized system, but the United States has retained a pretty privately oriented, voluntary, with an exception of how the Affordable Care Act treated it, voluntary employer-based system that pretty much grew up because we didn't have a nationalized system in the kind of run up to World War II and then afterwards. And employers sort of got in the business because at that point, really beginning in the 20s and 30s and the 40s, it was really during those years that medical care started to be beneficial. Right? Prior to that time, people wouldn't buy health insurance because there wasn't much the medical community was going to be able to do for you in a lot of circumstances. But once certain advances had been made, and those advances were expensive, you had to go into a hospital to be treated, then people say, yeah, I'd like to get health insurance because if that happens to me, I want it taken care of. Employers stepped in because there was no nationalized system and started offering it as a compensation provision to their benefit packages. And during World War II, when there were wage controls on cash payments, they allowed that as a non-controlled fringe benefit. So a lot of employers started jumping into it because they could attract employees by offering health care. It wasn't controlled by the government. And then the IRS stepped in and said it would be untaxed as well. And so therefore it became pretty popular to get an employer-based health care. The unions started pushing for it. So it spread really, really rapidly through the 50s and 60s and became the norm in the United States.
And so we have this massive employer-based system in which companies contract with insurance companies, I guess, really, basically, right?
Yes.
And under all kinds of federal regulations, and
yes.
state regulations, and whatever. And how does it work?
How does it
work? And talk about some of the proposals to reform it one way or the other.
Yeah. Well, there's sort of two options if you're an employer. The big employers, for the most part, self-insure. That is, they take on the responsibility of owing the claims that people have for their medical benefits under a law called ERISA that was enacted in the 70s. That allows them to get out from under state regulation of what they're doing. But it's a federal law that allows them to do it. So it's federally regulated sort of through the Department of Labor. But it's pretty open. They're allowed to design it the way they like. But they contract with insurance companies.
Because at the end of the day, some big
companies,
publishing company's not going to have expertise in figuring out how to do healthcare insurance. So they're
so they hired a Blue Cross plan or maybe multiple plans, Kaiser Permanente, United Healthcare. They hire one of these big insurance plans to organize the doctors and hospitals that their employees go to see in network. Okay. So that's sort of one option. You can do it yourself and hire an insurance company to sort of run it for you. Or you can be an employer that just says, I'm going to buy insurance from an insurance company. I don't organize it. I don't do anything. I don't self-insure. It's just a premium payment to an insurance plan. That is state regulated. And in the states, for fully insured products like that, the states have historic jurisdiction for the regulation of insurance and retained it even under the Affordable Care Act, although with lots of rules now. So those are your two basic options. Now, for reform, it's interesting. Remember in the run-up to the Affordable Care Act in 2009 and 10, President Obama had said previous to that time that he was in favor of single-payer health care as a candidate. But, politically he looked at it and said, it's really not possible to upend this sort of embedded arrangement.
Single payer, just to be clear, would be...
Single payer means that the government takes over the
We pay more
insurance.
taxes. The U.S. government pays when you go to Sibley Hospital and get whatever treatment you get.
Right. Instead of paying premiums to an insurance plan, Americans would pay taxes to the federal government, presumably, or the state government. And the government,
They
federal...
could still have co-pays, I suppose, and that kind of thing. That would be
You could.
question.
Most single-payer plans do not,
Right.
on a principle of free at the point of
So
service.
it's just, you just
Yeah.
show up and they
You
do what
just show up and
they
they take
have
care
to
of
do, and you leave the hospital and there's no bill and no paperwork.
No paperwork.
And people love that part of the system, it seems like, or they love the idea of that part of the system.
They do.
When they're dealing with the paperwork
Yeah.
after they've been home from the hospital for 2 weeks and this has been paid and that one wasn't paid and this one sent to the wrong company and so forth, right?
Right, and then you have to justify things and
Right.
call back and get on an 800 number and nobody
Right.
misses the
And
phone.
get your doctor to send a note saying this was necessary,
Necessary.
but your doctor has better things to do than send notes.
Send notes to the insurance
Yeah.
company. Yeah. No, the whole business of dealing with private insurance is a source of frustration in the United States and a source of, joy that they don't have to do it in most other countries. The polling for single payer is high. In other words, the citizens of countries that have it like it and don't really want to take on the responsibility of being someone who has to navigate a health system and think about financial aspects of it. They'd rather not deal with it and have the government deal with it. And as long as it, think of it this way, in those countries, this is part of our later conversation, but in those countries, most people are relatively healthy. So unless you are someone who's really sick and need of very, very expensive care, high expertise care, maybe you don't miss the open aspect of the United States system as much, and you're fine with sort of more routine interactions with the health system. Someone can fix your broken leg, your child has a fever. Those kinds of things are pretty routine, and a primary care system can take care of it. It's really when you're really sick, the question is which system would be better for you. So those are the kinds of questions that come up when you start thinking about that kind of a model. But back to our employer discussion, you can do it either through your own self-insured plan or through a state. But what I was going to get at is that it's very difficult to dislodge the system in the United States. That it's a big system. Under 65-year-olds, there'd be 160 million people, that is the workers and their families, are pretty much been in this system. And that's an awful lot of people. And, they're in Blue Cross plans, they're in Kaiser Permanente, they're in United Healthcare, they're in these big insurance plans. And for the most part, frustrating as it sometimes can be, they know that plan gives them what I would say is the way to understand is ready access to very good care if they need it. So I think that's the thing that makes it very difficult to take it away. They know that if you're in a Blue Cross plan, and, heaven forbid, you end up with a diagnosis of cancer, or you get hit by it, you have a car accident, and you need a lot of care. They know that insurance plan is going to get them into the best hospital in town with the best surgeons, the best oncologists, and the most ready access to that system that you can imagine. And that's a source of great comfort to a lot of people, and they're loath to give that up to something where the government might start getting involved to say, wait a second, how much is this costing? And, so because of that, President Obama didn't take on the employer-based system, and it will remain an issue, I think, in the 2020 campaign as something that might be problematic for those people trying to propose a single-payer approach.
Medicare for all is the tag, but that really is single payer, basically.
It consciously is single payer.
And I suppose when you have single payer, the government has to, which we do have, I guess, in Medicare for people 65 and over, in a sense, right?
Yes, we have, in a sense, single payer for them, kind of.
But sort of put on top of a non-single payer system, so it probably works differently than it would in a real single payer system.
Right. Our Medicare system is single payer with an asterisk, in the sense that the government is the payer of claims to hospitals and doctors, and it sets the payment terms for that relationship. But I think one thing to keep in mind is there's another aspect of single payer that should be understood, which is that in some countries like the UK, the hospitals and physicians, in effect, work for the government. They are sort of the employees of the National Health Service, okay? In Canada, also a single-payer system, the government is the payer, but it's a private network of hospitals and physicians that accept the government payment when they take care of patients.
But of course, that government payment has to be limited or set, because otherwise the doctor shows up and says, "I'd like $10,000 for this procedure," and the government and everyone else is saying it's $1,000, and so that you get in effect, it's price setting, or right, and not in a negotiation, which I suppose is more the situation. Well, it is a negotiation, kind of, I guess, between the government and the hospitals or physicians, but
that's a really important point, which is that in our Medicare program, and the government pretty much has, through regulations, has the ability to tell the hospitals in the country, here's how much we will pay you for that particular service, and it's a take it or leave it basis. They do have, under the law, the authority to opt out of Medicare.
Right.
Basically, no hospital does it, and very, very few physicians do it, because to do so is to cut yourself off from 30% of your patient population, potentially, and your revenue base, and it becomes a non-viable option for a lot of specialists, especially, particularly because, these are the patients that actually need your service. So they don't do that. And they end up with, the government's in a very powerful position to say, here's how much we're going to pay. I do think it's a little bit different than it is in the UK or Canada here in Medicare, in the sense that the government knows they can only go so far, right? Because, at some point, people do have options. And so the government can set the rates low, but not so low that, for instance, they don't want Medicare to become like Medicaid, where a lot of physicians really do opt out. The payment rates in the Medicaid side, which are established at the state level, are quite a bit lower than Medicare in many instances, and as a consequence, the physicians have dropped out of Medicaid.
And I suppose Medicare, if I understand it correctly, it's kind of free riding on the private, not free riding, but it's riding on the private system, and so it will set rates lower than your actual insurance compensation for a working age person is. But it's 30% lower, whatever it is. But it's still lower than something that was set in a private negotiation, where so it somewhat avoids the problem, I suppose, of the government simply saying, "I'm sorry, we're just paying for this," or "We're not going to pay for something at all." Right? That's very rare, I think, in the U.S.
We don't. There's not very many instances of that. They have to have a pretty hard and fast case that it wasn't worthwhile clinically to be able to make that decision.
Right.
But you're right that.
Whereas one has the sense in some foreign countries, they just say, if you're over this age, the procedure is not available, because I guess they have data claiming to show that it has a low, relatively low success rate, or even if it succeeds, it only extends life for 3 years. Whatever. But
right. They have specific thresholds in the UK of when to introduce things that are measurable as beneficial to the patient's health, and they try to measure that quantitatively. I don't necessarily disagree with the thinking behind it, but it does result in the government saying from time to time, we're not going to make that available under these conditions. If you're over a certain age or this, they do it a little bit informally to avoid major disruption in the populace, right? But they do introduce into their system a way of rationing care to keep costs under control.
Whereas here, the physicians seem to have more, and the hospitals more leeway.
Absolutely.
Insurance companies can second guess them, and I'm sure they fight all the time. But if a physician says, well, this 68-year-old could benefit from this, even though a lot of 63-year-olds even don't, because he's or she's healthier or just whatever reason, my sense is that doesn't get automatically knocked out or disqualified. And there's in fact a certain deference to the, if it's a reputable hospital. And
there's a interesting thing that goes on in medical care, which is that there are still disagreements about what is the best clinical way to deal with certain things. And I would say you kind of look at how things evolve over time. You see that 95% of it everybody kind of agrees on, and it's pretty clear what the clinical answer should be for somebody under certain circumstances. But there is 5 or 10% out there that still rely on judgment, and it's not hard and fast, and those are a little bit harder cases, and physician judgment plays a big role in that, and I think probably rightfully so. I think we all know of cases of of people who were given certain advice about their treatment plan, maybe didn't follow it, followed a different course, and ended up better off for not following the original advice. And so I think that's an indication that while a lot of this can be reduced to pretty scientific clinical answers, not all of it can be. There's still a little bit of judgment involved because it's still murky sometimes.
But all this costs a lot of money.
Yeah.
And some of which the federal government pays, and some of which we all pay through premiums and through insurance premiums, I suppose, or through direct payments.
Right. I mean, just to get into this a little bit, the Medicare and Medicaid programs are the number one source of fiscal distress for our government. And it's because cost for this type of system that we have is very, very high. We talked a lot about the good aspects of our system. And I'm, obviously very much in favor of all of that. But we have to admit to ourselves that our system lacks a certain discipline, and that lack of discipline is problematic. It's making it so that Medicare and Medicaid, in particular, financed through taxpayer money, are becoming heavy, heavy burdens on the national government, and will become really heavy burdens as the population ages.
But even the non-Medicare, Medicaid parts are more expensive than
Absolutely.
in other countries. We spend what percent of GDP? I don't know.
We're at 19% of GDP.
On healthcare.
Yeah, and most countries are, even rich countries like Germany, they're down in 11, 12. I think France and Switzerland may be a little closer to us, but lots of other countries are well below us. Certainly the UK and Canada, are well below us. And even, a country like Japan tightly controls their expenditures. So there's a big gap between us and our next high income countries, and some of that is justifiable, right? There is a pretty clear connection between the higher your income, the more you spend on health. Health is a preferred good, so as you become richer, the demand for medical care goes up even more than your income went up. Okay, because it's something that, the next extra dollar, if you've met all your basic human needs, and now you've got another little increment of income coming in, what do you do with it? You say, I'd really like to make sure my health stays well. And we do that as a collective society as well through our research efforts and other things. And so the higher the income, the more you're going to spend on health. So the fact that we do have higher incomes than Canada and Europe and Japan means that we are going to spend more than them. So that's one explanation.
Some of that expenditure pays for research and so
It
forth,
does.
which advances care
It does.
for everyone ultimately.
As the president likes to point out, we're carrying a lot of weight for the whole world. So that's important to understand. But a good portion of the gap is also waste. That our system is quite wasteful. It's overbuilt. There's lots of disconnects. It's fragmented. People end up getting duplicative care. You end up seeing a specialist. They're not sure what to do. They send you another specialist. You get the same set of tests run again. It happens still all the time. And, that kind of stuff goes on in the United States in a way that probably doesn't go on in other countries where they try to more tightly control those things or pay much less for those diagnostic tests. And, that kind of stuff adds up. You do it over and over and over again throughout sort of a big, complex system. And there's a fair amount of stuff going on that is really not benefiting the patients very much. And that's where, the focus and energy needs to be to sort of say we need to get rid of that. By the way, we also pay our clinicians well above what they're paid elsewhere. And, a lot of that would be justifiable. If it was a real market and we had orthopedic surgeons making 3 times what they were making in other countries, everybody, I think, would say, okay, that's fine. That's just the market is saying that's how much it's valued. The problem is our market signals are very weak and disconnected for a lot of reasons. And so therefore, the amounts that they're being paid, you're not quite sure they are reflective of the market signals or just we have excess payments going to certain
I was so struck when I got into the executive branch, when I came to Washington, and the education department, I was cushioned away from all that, not exposed to this, but then working in the White House. And we didn't do much with this stuff, obviously, directly. I mean, you all at OMB and at HHS dealt with it, but I don't know, for whatever reason, people would come maybe from the vice president's home state or whatever, or just to kind of meet, and you're suddenly being lobbied on the reimbursements for particular procedures. And it was like, I don't have any idea what this should cost and whether it's fair or not for the government to do this or to require that, or to require that there be a registered nurse there for this, or that a registered nurse can't do this because it has to be a physician. And I mean, I don't know if there's any way to avoid that really. There have to be rules, but there'll be rules, certainly if there's federal money involved.
Yeah.
And then once there are rules, they're going to be sort of arbitrary, I guess, and then everyone's going to lobby for changes in the rules. And that does seem like a little bit, maybe it's just a free country and that's how democracy works. But there's something a little crazy about the degree of it, I would say. When you worked on the Hill, it's unbelievable, right? Every single specialty is up there lobbying, every single subgroup of technicians and nurses and doctors. And
remember, what they're lobbying on is it's a massive system. And so there's, Congress is overwhelmed really with people pushing their particular issues on the health system. But the dominant issue there is Medicare's payments. So this gets back to, again, what we're talking about, which is that because Medicare is the payer, they know that lobbying Congress or going to HHS directly about the regulatory side, saying we need this or we need that, they can influence the payments that they get as practitioners. And so it's a huge industry effort to kind of keep their payments high in the Medicare program, or as high as they can get them. So, the question is, if we move to a system that was dominated only with Medicare for all, would that go away or would it just intensify? I think it would intensify. And, the Medicare system, the one thing about it that is important to understand is that it can be somewhat rigid relative to the private system, in the sense that when the Medicare regulations are put out, you have to wait a whole year to change things. You have to go through the regulatory process to change things. So let's say somebody's being overpaid, and somebody brings to HHS's attention, hey, this is being overpaid. Let's cut it back. It's a heck of a fight to get that done, right? But if a private company was found to be overpaying, 8 or 10 times, they can make the change if they want to, and nobody has to approve it. So I think those are the things that have to be thought through if people really think, giving it all control to the government would actually work out better.
So there's sort of two ways the reformers seem to go. It's oversimplified. The left wants something more government, something approaching Medicare for all, or at least the single payer option or public option, I guess they call it. The right has tended to want to introduce more competition and sometimes to disestablish the employer-based systems, have it more like car insurance or home insurance. That seems to work fine. There's a lot of competition. You go shop, you buy one. They seem to pay up okay,
Sometimes with some complaining.
With some complaining, but some state and state regulation and supervision. And so that's sort of the two sort of basic models. Basic models and so talk a little bit about
what's going on there.
The merits of each and the politics of it, and where do you think we're actually going to go? I mean,
Well, it's a good question where we're going to go. I mean, I think the thing that people that are market proponents need to understand is that the other side has one pretty powerful argument, which is that our peer countries have all pretty much adopted the governmental model. They haven't really adopted a market model. There's a couple of minor exceptions, but for by and large, if you look at Germany and France and the UK and Japan and Australia and Canada, I mean, they long ago decided they wanted to publicly regulate their health systems to try to keep costs under control and to provide a relatively uniform system of accessing care so that people more or less got equal, at least from some measure, entry points into the system.
Right, if it's a right or if it's a good that everyone deserves, it'd be like public education.
There's
better and worse.
Yeah.
Where you live, maybe depending on where you live and other
and of course,
things. But at the end of the day, everyone has the right to go to a public school. They don't pay anything, and presumably state regulations keep the quality somewhat comparable. So that would be the model, I suppose.
That's the model. That's the way it went, and they long ago adopted that. And so for proponents, for people in the United States, they have a powerful argument that says, why did they do that? It's because, A, it's hard to do a market-driven approach. So we'll get to that in a second. And B, that no one's been able to prove that a market-driven approach couldn't overcome some of the equity concerns that people have with it, right? If everything's allocated based on price,
Right.
so a market system by necessity has some price element in it. If things are allocated by price, then they say, well, doesn't that mean that people that can pay a higher price get better care? Okay. And of course, there's like in all these arguments, there's an element of truth to that then they parlay into saying, well, we really should just regulate it totally and run it through the public system. So that's their pro. Their con, what's wrong with that approach is that when the government takes things over, as it has in these other countries, they do have a very strong tendency to undercapitalize high-end care. So they don't spend enough on their inpatient facilities, and they decay over time. They are slow to adapt, so they don't bring in new innovation as rapidly as our open system. And they are they have a tendency, because of price setting, toward queues as a way of allocating resources. So they say, we provide that service, but it's going to be 6 months from now,
right.
Literally. And so if you got a real major health problem, 6 months is a long time to wait. Okay, and even 2 months can be a long time to wait if things aren't right for you physically. And so there's a lot of patients who suffer in these high-income countries because they've controlled the supply and through price setting, and that drives out willing suppliers. And that means that there's still somebody who can provide that very high-end necessary care, but it may be only one or two in the whole country, and people have to line up to get to them.
I guess some of these countries have the two-tier systems where, like public schools, they can be private schools, and there people pay as much as they want, and they get
it's like a safety valve.
More value for so the wealthy kind of get out of the public system.
They do.
But then the equity argument cuts the other way, it seems to me, which is there's more inequity probably.
Right.
More
Depending
inequality.
Right. Depending on which country, some countries that's more pronounced than others, and the only time you can get to the best doctors and hospitals is by buying private insurance.
Yeah.
A lot of countries, it's more the exception than the rule.
Right.
Okay, so the people by and large use the public system and just grin and bear the weights they have to go through. So the UK and Canada in particular, they've been battling this issue of waiting lists and queues for decades. Successive governments of both, all different political stripes have all promised to fix the problem.
Right.
And sometimes they do fix it for, moderately for a while, but then it comes back. And it's a very difficult problem to stay ahead of. And so you end up with waiting lists. And that's something I think in the United States would be very problematic. So that's the public side. Now on the market side, if you don't want public regulation of costs, the only alternative is to discipline it through some kind of market mechanism where people on the margins have a choice. They can pay for it, but when they pay for it, if they pick something that's more expensive, even though it may not be higher quality, they have to pay for it out of their own pocket. So at some point in the U.S. system, we need to have more of that occurring if we want cost discipline, and we don't have nearly enough of it for a variety
why aren't
of
the
reasons.
companies enforcing?
That's a good.
The American Enterprise Institute has a which provides health insurance, I assume, has an incentive, and there's a lot of smart people there, and they have an incentive to purchase the best insurance for the least, or not the best, but the most cost-effective insurance for their staff and employees. So that presumably should take care of that. That's what you want in a market system, right? There's
Absolutely.
A purchaser who has an incentive to pay less, and
Yeah.
suppliers who compete, and
Right.
say,
So a small employer with 250 or 300 employees, they go out to buy insurance, and they want to get the best for their workers at the lowest premium, lowest price. Absolutely true. One thing to keep in mind is, though, they are offering this benefit as compensation to their workers. So they want their workers to be happy with what they offer them. Okay, so there's a real sensitivity on every employer, large and small, to say, well, it's true I want the lowest premium plan I can get, but I don't want all my employees saying, I got a lousy health plan at my office, I'd rather go to another employer to get a better health plan.
Right.
Okay, so there's competition amongst the employers to offer decent health coverage because it attracts workers. Okay, so that's a hindrance against cost control. The really big problem is that even if you had an employer that wanted to be super aggressive and they were kind of small, 250, 500 employees, even 1,000 employees, that's just way too small to influence this vast medical delivery system that is really the source of the cost structure. Insurance kind of is sort of a layer that buys you into this thing. But the
Yes.
costs are in the hospital system, the medical clinics, the physicians, the labs, the way that patients are taken care of, okay? Big teaching hospitals, okay? And you're a 250-person employer. You aren't going to get them to change their business practices for you, okay? So to really influence the cost structure in the United States, you have to sort of reach into this superstructure of how care is delivered to patients and figure out how to discipline that. That's a much bigger deal than one little employer trying to pick what health plan they are going to have for their workers. So it's a cumulative thing across a lot of employers. Also involves Medicare because it's the biggest purchaser, and it involves Medicaid. All of them would have to start pointing roughly in the same direction, which is we're going to still buy into this very high-end, high-quality system, but on the margins, we want our employees, the actual consumers of all this stuff, to have some incentive to say, I'd rather get, if someone's offering me just as high-end care, but they can do it for 10% less, and I got to save that money myself, put it in my own pocket, I'm interested in that. That's a market system. You'd have to have that multiplied across, tens of millions of Americans to start moderating this system war. And that's what's lacking. And it's hard to get because it's actually not that easy to do politically.
And you could argue, the intelligent liberals have argued this, it's not that easy to do even practically, because what am I going to do? Go to Georgetown Hospital and to GW Hospital and make my own one is 10% cheaper? How am I going to have a clue whether the actual care that's being offered for my problem that needs to be addressed is better or worse? I can read, I guess, the way you can do with other things, Consumer Reports and, Yelp and the equivalent, and study, read studies. I guess they would both advertise in a way that, we have an 87% success rate. And the other. But I don't know. That seems a little
realistic?
hard.
Yeah.
Is that crazy? I mean, is that realistic? I don't know.
Yeah. It depends on the type of care, right? If you go in and someone says you need to, you get this terrible diagnosis of a cancer and that you have to embark on some oncology treatment, at that point they don't really know what the care plan is going to be. So you're just entering into it. They're going to have to do a lot of testing, a lot of diagnostics. They're going to have to start something and then come back to you after a few months and say, here's where we are, and now we need to go this direction or that direction. And so it's not something you can shop for.
It's not like go to a restaurant. I like this one which costs $40 for dinner instead of this one which costs $55 for dinner. And I know the quality won't quite be the
you're going to start down the process of being cared for, and they're going to have to order a bunch of things you're not even sure at the beginning of the process what they're going to be. So you can't really plan for it and buy for it in advance. Now, having said that, we could have a system where a lot more care was price competitive, where you had a system where fairly routine things and common things are much more transparently priced in a way that consumers can digest and compare. So think of a natural childbirth, right? You find out that a mother is expecting a baby at 3 months. You could have a system in the United States where a natural childbirth, from caring for the expected mother through childbirth and then maybe the month afterwards, every system in the country said, here's the price we're going to charge for an uncomplicated natural delivery. That is something that could be price competitive. It's fairly routine, obviously common, happens all over. And the 5% of the cases that are kickouts that involve some complication that needs attention, they can be handled separately. But you could have, for the routine cases, a pretty price competitive system. It doesn't really exist today, but you could try to move in that direction through a number of things would have to take place. But that's the kind of thing that would have to be replicated across a lot of dimensions. Common knee surgeries, hip replacement,
or just routine care, right?
Or routine primary and preventive care.
Your kid has a fever, and you just want to make sure everything's okay and get the medicine for the.
There's a monthly fee model that could be tried for pediatric care. Instead of every time you go in, you're paying $20 or $30. A model that said you have 3 children, $40 a child. On a monthly fee, you get unlimited pediatric care to make sure that they're well, and that encompasses all the stuff they need. And instead of sort of the piecemeal approach that occurs today, which is much more complicated for a consumer to try to price shop for.
And why it doesn't happen now? Because the individual consumer, the individual family doesn't have either the incentive or even the ability really to shop in that way. You're steered by your insurance company into a certain providers, and that's that. And you don't go personally to say, can I get X?
Yeah.
You don't personally save X by going to the cheaper provider. It's all, you're part of a huge insurance pool, right? I mean,
that's pretty much it. Yeah. I mean, the whole system has been built up around an opaque insurance-led system where the insurer negotiates with the doctors and hospitals. They say what, between them, they decide what the payment's going to be. The beneficiary, the patient, pays a copayment, but that copayment doesn't vary really based on where they go that much. Sometimes it does, but if they stay in network, so to speak, that is within the insurer's preferred system, they're going to pay the same no matter what they do. So they don't really care. They don't have any incentive to price shop. So all of that would have to change if you wanted a more price competitive system. And, it's complicated to do, which is why it doesn't happen. Although I will give the administration some credit. They're tiptoeing up through a couple of regulations on price transparency of the hospital system. They're not there yet, but they're in the neighborhood sort of understanding, where this needs to go to allow for simple, on routine things, simple apples-to-apples comparisons on price. Right now, the whole system is built to not allow that to happen, but the administration is working hard to try to inch up to make that happen. The whole industry is against it, right? The insurers are against it, the hospitals are against it, the doctors are against it. That ought to be maybe a sign that's a good idea.
Yeah, that's interesting. Certainly conservatives for years have used the car insurance model that, you bring your car in for routine, the upkeep and stuff. You know the garages, you like one, you trust one, you don't like another one, offers a disc, they'll do the Virginia inspection for $19.99 instead of $25.99, you go to that one. But if you get a serious accident and the whole thing has to be overhauled, then then your insurance kicks in, you wouldn't know how to really price, the damage that's, what overhaul is really necessary to your engine and so forth. So that's really, more of a bargain between the insurance company and and various providers of the service.
Right.
Auto shops. So
this brings me to something I wanted to get into a little bit, just to mention, is that on the, you see, as you mentioned, there's sort of this choice. You can have public regulation of the system to discipline costs, or you can try to build in some more market incentives to discipline costs. Within the market incentive side, you have sort of two branches you can go down as well. You can have one where you try to rely a little bit on the consumer, the patient, to make some choices and navigate as an autonomous agent, kind of consumer, picking where they want to do things. That's the HSA model, health savings accounts, right?
And that's assuming that you're going to have some catastrophic insurance
at the high end,
catastrophic care for the high end, but people aren't going to navigate that and shouldn't really try that. But for the routine, as you say,
you use your HSA and you shop around a little bit. You have an incentive to try to keep your account big and growing. You try not to spend money if you don't need to. So the hope has been that would lead to that kind of a consumer approach. The other model, which, as you just indicated, they're not mutually exclusive. They can work a little bit in tandem. The other model is that the consumer hires someone to be their agent in navigating the system. And that's basically the insurance model. Now, here's really something very important, which is that people don't tend, sort of a distant commercial insurer, it's hard for people to hire them and say, please, run my managed care for me, run my HMO for me, okay? That's why the managed care push in the late 90s foundered a little bit. These big companies got into it heavily, and a lot of patients pushed back saying, I don't want you telling me.
That was really striking how much it foundered, right? Because it was really the new thing,
HMOs
and all this. And it didn't...
It ran into some problems, and the problem basically was distrust between the patient and the insurer. The patient saying, I'm not picking on one national insurer in particular, but pick your favorite villain national insurer. I don't want them deciding which hospital I go to or which doctor I use, especially. So, having said that, though, lots of patients in the United States are now enrolled in kind of what I would call provider-driven managed care. That is, actual hospitals and physician groups, in a sense, becoming their own managed care plans. Many of them have their own insurance attached to their system, so they are selling insurance to their patients and acting as an HMO on their behalf. And they become the agent to kind of navigate the system. Now, lots of people are a little worried about this kind of approach too. They say, gosh, it's an HMO, and there's a bureaucracy there. Do they really know what's best for all these patients too, and so on? I'd say I'm much more optimistic that if we invested and went down that road, it might pay pretty big dividends. I mean, the way to think about it is that not all care, but a lot of patient care can be examined pretty scientifically. And you could say, okay, somebody comes into a system, they're sick, we collect all the diagnostics on them, then we do a bunch of stuff to them, and then we spit them out. And then we track them. If you're a managed care system, you should track them and say, did they get better? Okay? And then they collect the data, and then they run it through their kind of care protocols. If they do that repeatedly for patient after patient after patient, you could start figuring out, what works and what doesn't. Okay? And honestly, that's sort of the good version of managed care. So I'm not, lots of people are in Kaiser and there are problems with Kaiser, and a lot of people are happy with it, some people not happy with it. But that kind of model done right lends itself to a pretty data-heavy approach to taking care of patients, and say, when someone comes in that looks like this, we know the cheapest, bestest way to take care of them. And we push them down that system, and 99% of the patients will get better. The 1% that we need to do more for, we'll kick out and take care of. So that's the good version of managed care, okay? Think of Intermountain Healthcare in Utah, okay? This is a big integrated health system where the doctors and hospitals are all kind of part of an organized system, okay? It's not fragmented and open like a lot of American healthcare. And it's those kind of systems that, when they're coupled with insurance, you could be a patient out there in Utah and say, I'm just going to hire Intermountain Healthcare. I don't have to deal with anything else. I pay them a premium. They tell me, and I trust them to, when I get cancer, here's the best way to take care of me.
Now, you pay them, but what about the employer? I mean,
and employers buy it too, of course. So it would be, their way of.
But if your employer doesn't buy it,
then they could buy Blue Cross, Blue Shield, or United Healthcare.
If you personally want the Intermountain, you're out of luck. So then you come back to the employer-based character of the system as checking some of the obvious ways you might get more, cost sensitivity or even accountability, right? I mean, in a funny way, it's a barrier to that because everyone's in the same pool.
Yeah.
And so you can't let individuals just leave, because then you have, the obvious insurance problems of,
right.
What's called, my mind's going, what's self-selection.
Yeah, risk selection.
Yeah, risk
adverse
selection.
selection.
Adverse selection and all that. But then, you don't personally have a choice. I mean, I was thinking about that. When you go to buy a house, you don't, or an apartment or something, you don't necessarily know how to evaluate the worth, how well each of these buildings is built, or or whatever, or these neighborhoods and stuff. But there are many people who get paid, many agents who buy and sell houses and hopefully have an interest in making the deal happen, and therefore have an interest in responding to what your concerns are, and then finding you what looks like a good deal at least. It's funny that doesn't happen in the healthcare system. I guess it doesn't because it's employer-based. But you think there'd be like a huge number of people who would be your guide to the healthcare system.
Yeah.
People would pay quite a lot, right? I mean,
they do, yeah. There's a broker system out there for people in the individual market for that very reason. So it was a pretty developed and sophisticated broker market that, people basically helping when someone had to navigate on their own and buy insurance. You could go to a broker, pay them a fee. They then would say, here are your options in our community, and here's what this one has. And they know the system pretty well. And that system, does work, right? It's a pretty market-driven system. I'd say that, back to the point about the employers being a barrier here, I agree with that if you had free agent consumers out there having to buy something to get their insurance, we'd have a dynamic that would be more beneficial toward the kind of discipline I'm looking for. And choice would drive toward lower cost, higher value options.
But I suppose what cuts the other way, correct me if I'm wrong, is that if you really had that system, you would lose the advantages of the employer pooling 300 AEI scholars or 1,000 people elsewhere.
Yeah.
Which then you get into all the obvious pre-existing condition problems, because if you individually have to go buy insurance, the insurance says, I got to charge you much more than the person here. You have a high likelihood, unfortunately, of this disease coming back. And then we say, no, you can't do that. But then suddenly you're on a regulated Right.
It's totally. I mean, I think
so you do. I mean, you can dislike the employer-based system, but when you think about it, you have to have some way of grouping. If it's insurance,
yeah. That we didn't even get into that before. You're making a very important point, which is another reason why the employer system grew up was a natural, non-health way of buying group coverage. In other words, although people are working, and that is a certain self-selection involved in that itself, right? If you're disabled, it's hard to work. But if you're not disabled and you're basically healthy, you go to work, then the normal risk factors, genetic and otherwise, that apply are generally uniform throughout a big employer. And so you have a good way of spreading the risk, okay? If you don't have that what you need in the individual market, you're going to end up with some regulation. I'm not one of these people that thinks you're going to have an unregulated individual market.
I mean, the way the individual market in car insurance handles that, if you have 8 accidents, you pay a lot more than if you have one. And if you're 18, 19-year-old male, you pay a lot more than if you're a 52-year-old person who's never had an accident. But we don't want to really go down that road. I don't think in health. You don't want to say that someone has bad luck of having this or having had a disease or whatever, or having been in an accident, which then leaves him or her vulnerable to things, has to pay more. So once you say you can't pay more, though, then you're into sort of back into price setting, basically,
or just saying
community
that
rating of a kind.
some way of protecting people. I mean, you could the inverse of what they did in the Affordable Care Act is said that if you stayed insured, you were going to be treated like everybody else. If you tried to game the system, and you went out and said, I don't want to buy insurance because I'm healthy now, and I'm not going to buy insurance, and then I could try to get back in later after I've got a condition, then you got penalized.
Yeah, that was the famous mandate.
Right, exactly. So, the Affordable Care Act tried to do it differently by mandating everybody to participate. You could have done it the other way, just said, hey, if you jump out and then try to get back in, you're going to have to pay a penalty.
Right.
Either way, the same concept applies, which is, hey, we kind of want people when they're in the system not to be penalized based on their health status. Because it is a little bit hard to justify, right? I mean, unlike the car accident analogy, most things that people end up with are, misfortune and not, strictly related to their own personal behavior. There are things that are obviously smoking and things.
But even then, you don't want to you're not going to not provide care to people, even if it is due to their personal behavior. So you're sort of, at the end of the day, there you are.
Yeah, there you are, right.
Providing care.
Yeah.
So where does this, well, I was going to ask where this all goes to conclude, but maybe if we missed anything really fundamental in terms of
it's a big
how much of the system is paid for now by the government?
It's about half of the dollars are federally financed.
So there's 90% of GDP and 9 or 10% or whatever of that is federal budget.
Yeah,
federal and state budgets. And that's why Medicare and Medicaid are such big chunks of the federal budget.
Big chunks of the budget, yeah. Really big chunks.
And then the other half is private sector of one kind.
Exactly.
Or another. And is that continuing to grow as fast as it once was, or is it sort of topped off and have we hit some kind of natural limit of where you can...
Things have moderated a little bit over the last 15 or 20 years, particularly actually in the public programs relative to the private. And there's lots of disputes about why that's occurred. It's probably a combination of factors, one being that we have higher deductibles. So there is some evidence that people are foregoing some care, not price shopping, but they just don't get some things because they think to themselves, I don't want to spend $200 on this. I'm not going to get it. So when you have a high deductible plan, even with an HSA, the evidence indicates that people use a little bit less care. So because of high deductibles are now fairly widespread in the commercial sector, that is happening more and more. The second factor is improvements in certain diseases. So heart disease, especially, is being cared for a lot better than it used to be. And so you just have fewer heart attacks. And that's a big deal.
Drugs are cheaper than hospital stays.
Exactly.
Mostly.
Yeah, exactly. And so that's another big deal. And the third one, we had a financial crash. And use of healthcare is directly related to our income. And so when we have less income, people use less services. So that's another factor. It's global, not just in the United States. I do want to mention one thing before we get to our conclude, which is that when we compare the United States to other countries in terms of their overall health system, one thing I forgot to mention, which is also important, which is things spill into the United States system that don't spill into other countries' systems. What do I mean by that? Is that basically on a couple of dimensions, things that the number of people that end up in trauma in our emergency rooms is way, way above what
Right.
it is in our peer countries for a couple of reasons.
Gunshots.
We have some
drugs,
social,
right.
societal things that go on in the United States that do not go on in other countries. And some of that ends up spilling into how much we spend on healthcare.
Yeah, no, I mean, it's kind of a liberal gun control talking point, but nonetheless true that if you have 100,000 people showing up in emergency rooms, I'm making up that number, but it's got to be
It's a big
something
number.
like that's a big number. We get 30,000
With
people
knife
get killed.
wounds.
Yeah,
and
showing up in
guns.
emergency rooms with
Yeah.
gunshot wounds or knife wounds, and in some other country it's 10% of that. That's going to affect your medical
It
costs.
does. And the other one being, accidents, car accidents on more open highways and so on. And so those are big ones.
Yeah.
And between the two of them, they add a non-trivial increment to how much the U.S. spends on medical care relative to, and lots of studies have compared it to Canada in particular, right across the border, very similar cultures in a lot of ways, but those two dimensions are different in Canada than the United States, and they end up spending less as a result.
Yeah, that's interesting. So what do you think over the next year or two, next 5 or 10 years in terms of public policy? I mean, which way is the debate likely to go, or could it go, or
Yeah.
what will it be the big flashpoints, do you think? I mean,
I think that the Democratic Party, as they get into 2020, I think there's lots of talk inside their own party about what they're going to do. A lot depends on the candidate they pick, but I think almost irrespective, unless it's Biden or Warren, if it's any of the others, I know that's a big if, but
yeah.
then I think they're going to migrate to something like a public option, something that appeals to the party. It doesn't threaten the employer-based system, and allows them to say we're introducing more public insurance.
And how does the public option work? So if you are at AI, you can say to AI, no thanks, I'm going to take the public option, which is in effect Medicare type situation.
Yes. It depends on how they introduce it. They probably would introduce it first just inside the Affordable Care Act exchanges, which is
So
the
that's-
individual insurance
So for
market.
the individual market, right.
So they say, okay, we've got these competing insurance plans out there. That's working not so great. Let's introduce a actual public option into that, which President Obama favored in 2009 and 10. Couldn't get it through the Senate, so that's why it dropped out. It's particularly Biden, obviously, but I think a couple of the other candidates, if they were to break through, it's the clear answer for the Democratic Party in 2020. A popular position that's much safer for them politically than Medicare for all.
And fixing Obamacare
And
in accord with
building on
it, as
Obamacare.
they say.
Yeah. So I think that's the smart play for them. For President
Would
Trump,
it have an actual radical effect in the real world, or just cost a little money?
it would be consequential. It'd be a 5 or 10 year play. It'd take a while for it to kind of mature, but one could imagine in 5 or 10 years a public option having, it'd be like another increment to Medicare and Medicaid. Another 30 million people are in the public option.
So it's a big,
So
adds
it's
up,
it's a big, but it's not 200 million people.
and it's not taking away individuals.
It's not taking away choice.
Provided health insurance.
And
which
so I
is-
think the vast majority of employers would continue on as they're doing because people would prefer that. Their workers would prefer that. But some number would end up in the public option, and because it would be a rate-regulated system. Now, a key aspect of it, one thing that is very complicated but important, is how do they get the doctors to participate in a public option?
Right.
The formulation now in Congress, Senator Bennett's idea, called Medicare X, is to make them. To tell them essentially, hey, if you take Medicare, regular Medicare, you also have to take the public option, okay? That would be a big controversial thing in the physician community and tough to pass. So if they sever that and make it totally voluntary for the physicians, then it won't get so big and it won't get so dominant. And I think that may be actually where that ends up over time.
So that would be the sort of moderate Democratic alternative.
Yeah.
Do you think there's some reasonable chance they go for some real Medicare for all kind of
I think
single
if
payer?
Sanders were to win the presidency, there's no doubt he'd try. And if Senator Warren were to win, I think she would try also. I think it would be a 5, 10, 20-year transition, right? I mean, but they would try to get something through. I don't think it would pass.
Yeah,
I think the politics are way too complicated. We have a vast, major health system in the United States. It's very big, and it's a super tanker. And even the Affordable Care Act, we had this raucous 10 years ago, I had this raucous debate. And the super tanker, I'd say, is still sailing more or less in the same direction.
Right.
Than it was prior to the enactment.
Now, I
of the
feel like we
Affordable-
published a million things in the Weekly Standard about it, and you wrote many
Yeah,
of
I
them.
wrote many of them.
And it was important and all that, but somehow one does feel like a little bit, what was that debate about exactly? It was about the individual market, which is
Pre-existing conditions in the individual
Right, two
market,
things,
and a
Joe.
pretty big pretty big expansion of Medicaid.
Yeah.
This most important provision really was
is expansion of Medicaid.
Expansion of Medicaid. Yeah.
But at the end of the day, the big system doesn't look that wildly different.
No.
Pre-existing conditions was already happening, sort of, right?
Because
in the 90s, there'd been legislation.
90% of the problem had been taken care of. They took care of the last 10%.
Yeah.
They made a big deal of it. It was a big deal for that 10%.
Yeah.
But most people were already protected for their pre-existing conditions.
So then the conservative alternative, but I want to ask one question which I forgot earlier, which is how much is it true that we must have data on this? One of the criticisms of the employer-based health insurance system we have is it has all kinds of other side effects that are not good. I mean, that it slows down people's willingness to leave one job and go to another, so it slows down job mobility, geographical mobility. It sort of makes the general economic situation, economic mobility in a way more sclerotic and so forth. Do you buy that, or is that overdone?
I think it's slightly overdone. There's a little bit of truth to it, and I'd like to see our system be a little bit more adaptable to make it easier for people to get insurance on their own when they want to. And I think actually the Affordable Care Act, I have lots of problems with it, but did point in that direction, right? You can now, if you want to start your own company, you can buy insurance on the Affordable Care Act for 2 years while you get it started, and it's pretty guaranteed you can get something. Okay, so that wasn't always the case in every situation,
And COBRA, I guess, where you leave a job, you can.
Yeah, that doesn't work that great, but that did help a little bit for a time.
Yeah.
But here's the big argument for the employer-based system, which is that, and it's a political argument, which is that if we didn't have it, if it was more broken up, wouldn't it be easier for proponents of a government-run system just to swoop away the whole system and move it into the government? I think the employer system is the major bulwark against the government taking over all of healthcare. And so in some ways I have some problems with it, but for that reason alone, I see its value.
I mean, I guess if you want to put it in political science terms, these are 40-year-old political science terms when I studied this, but I mean, kind of interest group pluralism, big interest groups have their problems. In terms of producing good policy and in terms of accountability and citizen even choice, because they're these massive institutes. But on the other, one thing they do tend to block is government take over everything.
Yeah.
Precisely because they are these big interest groups that can't just be pushed around at the whim of some president who comes in.
Right, exactly. Because there's a lot of workers behind it, and they like it and don't want it to go away.
And doctors and
doctors
employees and if it's 90% of GDP, it must be some percentage that's comparable of the workforce. Right?
It's a huge portion of it. Yeah, it's I'm not sure I could quantify it, but you're right.
And cities have boomed because they've been medical centers, and suddenly their congressman doesn't want to,
Right.
If you're the kind
we have, look, I mean, we complain a lot about our higher education system, and we complain a lot about our medical system, but if you're somewhere globally and you want to go to the best universities in the world, you go to the UK or here. And if you have a big problem medically, you want to come to the United States.
So what would the conservative agenda be then, sort of, as opposed to let's leave Trump aside almost and just say there's a stomach once again for getting back onto the more conservative healthcare reform side of things.
Right.
Which may be happening a little beneath the surface in the Trump administration, but nothing.
A little bit, yeah.
But nothing legislatively since the fiasco of the repeal and replace.
Right. Well, I mean, the president, we don't need to dwell on his role in this, but they are signaling that he might give a speech in the next couple of months. Now, we all know that that's not necessarily a reliable indicator of whether he will give a speech, but they've talked about it enough that it might happen, right? So there could be a foray into this at the presidential level in the next few months. Who knows? I think the problem for conservatives is they need to take the next step. They talk the talk, but they need to walk the walk on a market-driven system. Right? If you don't want, what is driving people to want Medicare for all? Of course, there's some aspect. I'd like to make sure everybody has insurance. There's a little bit of an ideological, historical aspect to it. But there is an element also of this thing is such a hassle. It costs a lot of money, and it's hard to navigate. And these other countries, they seem to have simplified it by the government taking it over, and they don't pay anything. And I think this cost side really is a big deal. And the system needs to be more responsive in terms of keeping costs under control and helping the patient make it easy for them to navigate. How does that happen? Well, I mean, it's like anything else. A market could deliver those benefits to patients, lower costs, and easier to navigate approach. But it has to have an incentive to do that. And only if you want a market system, somewhere along the way, as I keep emphasizing, someone has to choose lower cost and higher value. Someone has to say, I'd rather pay less, get more, and I'm told that if I go this direction, I'm going to be able to get that. And I'll save, $100 a month in my own pocket if I make that choice. And the way you do that is, instead of open-ended subsidization that occurs in a lot of different ways now, you close it off. You say, for Medicare, you're going to get $10,000. You're not going to get $10,500, okay? So here's $10,000. Buy the best plan you can. If you buy a $12,000 plan, you pay $2,000. If you buy an $11,000 plan, you only pay $1,000.
And the sellers can't discriminate against you, though, if you have
no, it's
a
all
pre-existing
regulated.
condition. So it's
regulated,
even,
and it's fair competition in terms of same benefits. It's really, the question becomes, like I was trying to say, you're hiring an agent through that choice to keep the costs under control. So the truth is, if you put up that kind of choice in Medicare, a lot more people would end up in more tightly run HMOs. Good HMOs, I believe, that would weed out some of the nonsense that's costing the system a lot of money.
And this was basically Paul Ryan's plan.
Yes.
And this is basically the conservative, the Republican
Premium
way
support
to reduce the rate of growth
in healthcare.
and especially in Medicare
Yes.
and Medicaid, I suppose.
You replicate that in Medicare. You do something similar in the employer system by changing how we work the tax preference, okay? And those two are the biggest players. Medicare and the employer system are the biggest players in American healthcare. You point both of those in the direction where the participants in it have an incentive to go low cost, high value. You'll start to get a dynamic where the delivery system, that is all the hospitals and doctors, have to be responsive to it and cut their costs and get into systems that will be less expensive. So you need, if we don't want eventually public regulation of pricing, that's really the road we got to go down.
I should think the transparency part of that would be important, and the sort of result, making results public and explaining them and so forth. Because, if some hospital has to abandon, some procedure number 5 because they're now competing in price, if they can say, look, we are abandoning this procedure, which we've done for 20 years, but here are the studies that show that this procedure number 5 gives us no additional
It doesn't really help the
outcome,
patient.
doesn't really help the patient. Or in the instances where we think it would, we would add it, but, et cetera, but we're not going to routinely provide it. If someone could say that, people would say, fine. I mean, that's if that's a legitimate, so that's where I think the whole, the opaqueness of it is a problem now.
Yeah.
You have no idea what is really necessary, and you're not going to you don't want to start second guessing your physician, but even other non-physicians at hospitals and so forth. And then there's, I suppose, a lot of preventive medicine for legal reasons and stuff. I don't know.
It's critically important in that kind of a system that we have a lot of attempted oversight of our medical system, and that would have to even get better if you had a market-driven approach where the quality was measured carefully, and there was a system that said, here's basically the standard of care, and if you're not getting it, then they're mistreating you in that system, and they shouldn't be doing that. So it's a lot of, medical care is really important on this really fundamental thing, which is sort of false positives and negatives, right? So a lot of people end up getting back surgery in the United States, and then a lot of people say, you know what, we do too much of it. That, we end up not really helping a lot of patients because they're getting their backs operated on when physical therapy and other steps really could have taken care of their problem first. Back surgery is obviously very, very expensive, okay, and the recuperation is difficult. On the other hand, there are some patients who need back surgery, and they're not going to benefit. They're not going to get better without it, and you don't want them suffering for 3, 4, 5, 10 years because people saying, no, we can help you this other way, when actually what they need is back surgery, right? So the system has to be refined and delicate. It has to know when to steer people which way, right? And that's not easy to do. And so there are no hard and fast rules here. You need it to be adaptable and open and monitored and constantly reviewed.
But with some market incentives, is what you're saying.
With some
you really
market
can't
incentives.
do it without that. From the
cost side, for sure.
Cost side from the conservative. You can do it with price controls, but then you have your own other set of
problems.
Issues.
Price controls almost always descend into supply problems.
Yeah, that's queuing, and that's
queuing, and also good people leaving the professions and not drawing the highest talent.
and then getting the quality question.
And the quality question arose slowly over time. It's one of these things, though. If we went down that road, people wouldn't notice that the quality was worse till 3 decades later, right? And obviously then it's too late.
Yeah, no, I think the quality, coming back, I'm glad we ended up coming back to the quality thing, because it is so important, and it seems to be taken for granted, and people go on and on about the 90% of GDP and stuff like that. So, you know what, if we're getting a lot better medical care and it costs 90% of 19 cents on every dollar in the country, I don't know, is that the worst thing in the world? What else are we spending the money on? We spend 5 cents of GDP on defense and stuff and related national security expenditures, which I'm for, and maybe that should be a little higher. And we spend other things on education and infrastructure. That's all fine, but it's not crazy. It's not, people talk about it sometimes as if it's obviously nuts to spend close to 20 cents on the dollar on healthcare. I don't know. It's kind of an important good for people,
Very important. I think it's the sort of like, it's the first thing, right? You need to be educated and you need to have good health. And so, without those two things, lots of other things suffer. So, it's a starting point for what people will value in life.
Well, Jim, thanks very much. I've learned a lot, and I think it stimulates further thinking about things, and at least allows, I hope, our viewers and listeners to begin to at least evaluate these debates they are conducted so often in such a shorthand way, and it's sort of in a demagogic way too, right? Here's one anecdote, and then we're supposed to reform the whole system because this one person probably did really get bad care or something like that, or got good care in some other country or something. So anyway, thank you, Jim.
You're welcome.
Thank you, Jim Capretta, for being with us today, and thank you for joining us on Conversations.